Okay, we'll call the roll.
Okay, please answer when your name is called. Robert Winchell.
Here.
Joseph Schenker.
Here.
Michael Vatch. Robert Ackerman.
Here.
Nicholas Alexandru.
Here.
Christopher Graziano.
Here.
Eric Cohen. Mimi Langston. Kevin Munjal.
Here.
Cindy Basilios. Dario Gonzalez.
Here.
Glennis Seda. Bradley Kaufman. Doug Isaacs.
Here.
Nathan Reisman.
Here.
Joshua Buckland. Barbara Aziz. I thought Barbara was here.
She's here.
Barbara is here.
Allison Burke. Jeffrey Rabrich.
Here.
Heidi Cordy. Neil Floenbaum. Louis Marshall.
Here.
Michael Redlener. Michael Hilton. Lori Ivacoli. Stuart Kessler. Pamela Lai.
Here.
Dominic Battinelli. I thought Dominic was here.
He's here.
Okay.
He's here. That's why.
Scott Chang.
Here.
Peter Wire.
Here.
Paul Barbara.
He's here. He's here.
David Benelli.
Right to your right.
Celia Quinn.
Here.
Timothy Stiles. Mark Cantor.
Here.
Sharice Berry. Charles Martinez.
Present.
Joseph Bove. Martin Grillo. Matthew Isaac Harris. William Fisher. Robert Krupe.
Here.
Jessica Van Voorhees.
Here.
Arthur Cooper.
Here.
And we have, oh, Yadidja Langsam.
Here.
Anthony Shalish.
Here.
And Christopher Sorrentino. We have a quorum.
We have a quorum, excellent. So we're going to go a little bit out of order because some of our members have to leave to attend other events. So I'd like to move to medical standards first, even if we could address the NYPD ESU protocols first so that everyone can have their say. So there we go.
Sure. So medical standards met just before this meeting. The action items essentially that were brought were from the protocol committee. The first item is ESU protocols that were brought as second in motion from medical standards to REMAC for approval.
Okay. So those protocols were distributed by email. Everyone should have had an opportunity to see them. Is there discussion, for those that weren't at the last meeting, any discussion on the protocols? All right, seeing none, this will be a roll call vote because it's a protocol.
Okay, please answer in favor, oppose, or abstain when your name is called.
Further discussion? Did you?
This is the ESU protocol?
ESU protocol.
Okay.
Did you have further discussion before?
No.
Okay.
I just,
Yep, that's
I
what
didn't know
we're
it was
voting
to
on.
push those protocols.
No, this is the,
Yes, you. Okay. Robert Winchell.
In favor?
Joseph Schenker.
In favor.
Nicholas Alexandru.
Abstention.
Christopher Graziano.
In favor.
Kevin Munjal.
In favor.
Cindy Basilios.
In favor.
Dario Gonzalez.
No.
Glennis Seda. Bradley Kaufman.
no.
Doug Isaacs.
No.
Nathan Reisman.
Abstain.
Jeffrey Rabrich.
In favor.
Heidi Cordy. Neil Floenbaum. Louis Marshall.
In favor.
Michael Redlener. Or Michael
You have to
Hilton.
leave.
Pamela Lai.
No.
Laura Ivacoli. Paul Barbara.
In favor.
Peter Wire.
In favor.
David Benelli.
Abstain.
Celia Quinn.
In favor.
Mark Cantor.
In favor.
Charles Martinez.
In favor.
Jo-
Strong favor.
Okay. Joseph Bove. Matthew Harris. William Fisher. I thought Dr. Fisher was here.
I thought it was here.
Okay. Robert Krupe.
In favor.
Jessica Van Voorhees.
In favor.
Arthur Cooper.
In favor.
I believe that carries. Let me just count. 11, 12, 13, 14, 15, 16. Okay. Yeah, we have enough.
It's a majority of the
Yes.
Majority of
total,
the-
right?
Yes,
Yeah.
definitely. 1, 2, 3,
Same
4.
number of quorum, basically.
Yeah.
1, 2, 3. Yeah,
The
you
motion
have,
carries 16 in favor, 4 against, 3 abstain.
Okay, the next item that was brought for this, just as an FYI, to medical standards and to REMAC is the 3 CFR protocols that have already been approved in the past by REMAC, and as a matter of fact, CMAC, and didn't pass in SEMSCO, that discuss use of administration of aspirin to patients with chest pain, use of EpiPen, and assisting patients with their own albuterol in cases that they have asthma and they have wheezing. After we actually brought these protocols up to the state, it became apparent that these are already in the state CFR protocols and do not require actually approval, and hence we are just updating. Just updating medical standards and REMAC with those protocols. I don't think there's any need for vote on these.
Okay.
published.
The last item that was brought and is being brought from medical standards as second in motion is the use of push dose epi. There is some wording both for standing orders and medical control options in every protocol where there is treatment already for fluid refractory hypertension. Brad, perhaps you can read those 2 sentences if you have them.
I have the one sentence.
Okay, yeah.
Yes,
Here,
that's fine.
administer epinephrine 10 micrograms IV push slowly over 1 minute. May repeat epinephrine 10 micrograms IV push every 5 minutes, maximum 50 micrograms. Titrated to a mean arterial pressure greater than 65
It's not a mean
millimeters.
arterial pressure, it's a systolic.
Systolic pressure greater than.
That was
Systolic.
the draft.
Yeah.
It's not a mean arterial.
And this appears in all protocols where other pressors appear. Medical control option, though, in certain,
Where all of the pressors in the
Right.
protocol are medical control option.
That's where they
the
appear.
push dose epi is also medical control
standard
option.
order appears there.
Right.
Right. So it's basically follows the same pattern as the other pressors within the protocols as they exist. This is just an additional option of push dose.
Which we feel is a much easier way to manage patients rather than preparing drips and attaching the line and having the line kink or the arm of the patient bent, etc. It's just to allow our medics to provide needed care when appropriate in a much easier fashion. There was also some discussion about peri-intubation, hypertension, which was postponed and not being
So
discussed.
the motion that comes forward from medical standards is for what you just heard, where other pressors appear in those protocols, the option of push dose epinephrine is there. So discussion on this.
Just a question, do we have any sense as to how often pressors are used at all?
It's a good question. Do we, Fireground, have any data?
I certainly
on
don't
that, or-
object to, the protocol change.
I would say probably not all that often,
Yeah.
but I don't know that we have. Does anyone have data on this?
Part of the argument may be that it's not being used all that often because it takes too long to set the drip, and therefore they would get there sooner. So it may be used more often as a push than.
I got that, I just wondered if we had any hard data.
I don't think I have hard data, but anecdotally, I think any of us who do some of the QA from our own agency, medical control telemetry, I mean, all the post-cardiac arrest hypotensives, they're always getting the asking for dopamine or levo. And then we were extending it to the peri-intubation hypotensive, which is probably almost every pre-hospital intubation event. So I think it's actually probably much larger than we've been anecdotally seen.
Right, but it's, I don't think, to answer your question, Dr. Gibb, I don't think there is definitive data that we can provide.
I think it would be useful, I think, for the REMAC to see if one of our partners could take a look at that and see if we could find some data, just to give us a hint. And, it would seem to me that while I wouldn't anticipate would change the protocol, once we vote through, which I presume we will, it would be very nice to see if there is a change from the present to the.
I think that would be a good QA project, Dr. Barber, you want to?
So I think,
Right, that's what I'm suggesting.
Yes.
sort of answer Art's question is, we have specific instances where a patient can fit into the patient subset that has a protocol that has an option to give a vasopressor. But there are several patients out there that are in shock, that are untreated, but they don't fit a anaphylactic, severe sepsis, smoke inhalation, or cyanide exposure patient. And I, again, think that that's holding back our crews to not have just a unified shock protocol where anyone, peri-intubation, et cetera, can get into it by the very nature of being critically ill. And
So just a point of clarification, the peri-intubation use is not within this motion currently being.
but we all support it, Dr.
No, no, I
Rich.
understand that, I just want to make sure
We
we
all
all
support it.
understand what we're going to be voting
What
on.
we're doing now.
Right, that's
My
correct.
point was not to speak against
No, no,
the protocol.
that- right.
Just to ask for some data.
And what you're discussing is very important, but that's to come forward from protocol as
So,
a later.
again, I question who gets into the protocol.
Okay. Any other discussion on this protocol?
No, I think Paul's right. We need to kind of unify this and make it more streamlined. But right now, we all agree that push dose epinephrine is easier for medics in our region and probably more appropriate with our transport times than starting a drip. And if that's the case, we should have it as an option compared to those other pressors.
So one other thing I bring up about this is the impact this has on writing exam questions for the medics in the region. Dr. Alexander? So the impact this has on bringing up exam questions for the medics in the region. As the chair of the Certification and Credentialing Committee, I'm against this protocol because of the impact it will have. And it's going to be very difficult to write questions that are in protocols all over the place. It's much easier to write a clinical question that asks about a shock patient getting medication, not a patient with a systolic of 89 who may be clinically well, who has an allergic reaction, is now going to get a squirt of epinephrine.
Absolutely, and I think that we will move forward with that, with the unified protocol, but not at this point.
Dr. Schenker.
I just don't think that writing a test question should define how we change our protocols. I think making the right decisions about our protocols should influence how we write the test questions, but I don't know if it should go the other way. I hear you though, and I think, again, we all agree that a unified protocol is probably a better way to go, but right now I think this is appropriate considering what we have and what we need for the region.
Just to answer you, then I would suggest we have a discussion about what the purpose of the exam is. Because the purpose of the exam is to test the regional protocol knowledge for the providers on the street. And if we're not going to write questions based on the protocols that are in paper, what's the point of having the exam?
No, we should do that, but we shouldn't decide to make a protocol change because it's going to be a hard thing to test. That's what you're suggesting. You're suggesting because it's hard to ask test questions on this, we shouldn't write the protocol this way.
I'm suggesting the protocol doesn't move forward because it doesn't have.
So you could offer an amendment, 1 second.
Yeah, I actually agree with Paul that this should be a unified one thing, and not to do with the test, just to make it easier for our paramedics. And it always happens that we change protocols and we forget to do it in certain protocols. I think it would be safer and better that way.
Okay.
We certainly can bring that in protocol. We already have some stuff that's gone around by
So
email.
why are we passing this before it's
So
ready?
just a point of clarification, which came up at the last meeting, is that it was the attempt to get this into the public notice and therefore be able to be voted on in final form in September to go to CMAC, with the thought that after the public notice, it could be amended at that time. That's one option. If there's other things people want to make motions on.
Let's just
or
make it
suggest.
even more confusing for the people who have to use this. We're gonna pass something real quick and then change it.
Well, they're not
make
going
a
to use
plan
it when you
change
pass it real quick, right? It's got to be,
It still
it's
has
in the
to be
rollout, it's in the,
notice.
Yeah.
right, still have to go through the process. Dr. Gonzalez.
I just have a question. If we amend and change it, do we then have to put it back out for review? Because then people have
No,
reviewed
because then you're
something.
incorporating the public comment you got already into the, in other words, you put it out for public
It
comment.
sounds like this is a fixed court.
No, you can't do that.
Yeah, I don't think-
You can't do that.
I don't think you can do it.
A unified presser protocol would be a new protocol.
Correct.
It has not yet been discussed in protocol
You said you
committee.
can't do it.
Guys, I thought so let it go back.
Dr. Isaac.
So, let's just clear, so this is not changing, guys,
Dr. Isaacs has the floor.
So we're not changing the actual wording, it's just reorganizing it? Is that fair to say is why this wants to be put out for vote now and then look into public comment and just reorganizing it?
Right,
Or are we changing all the wording?
This is changes into existing protocols, and I think the point was made that a unified protocol would be a newly written protocol and not part of the existing protocol. Is that what you're saying? Sam? You may speak, you can ask the question.
In reference to what you just said, Dr. Shedder, this is not an either or, because there are times when push dose may be much faster to give, and we can use that as a temporizer while we get the IV. So the way you're stating this is or. So you could clarify?
I think he's asking a question.
Okay, so the answer is that with our transport times in our system, using push dose epi instead of putting a drip is probably better indicated in our system in most cases. Yes, there are always times where a drip might be appropriate, but in most cases, it's more appropriate to go with a push dose rather than a drip.
What I'm honing in on is, upstairs, mid-floor, walk, etc. I could give the push dose, get orders from both, give the push dose, well, it takes me a couple of minutes to assemble.
So most of the time, what you probably would get is just repeats of the push dose. But again, I think that's
So I'm just
beyond the
going to
scope
move
of
this
the question.
conversation along because one doesn't mutually exclude the other. They're both in the protocol as options. Dr. Alexander.
Yeah, so if I'm getting this correctly, this is a protocol that's being discussed to be a unified protocol?
No, that's what's being discussed, the changes that came forward for medical standards, which are changes within the specifically mentioned protocols to add this, what Brad read about push dose epi, in those protocols only.
It's only
A
in those
unified protocol is a separate issue that has not been discussed.
There was a draft that was handed out, which is not on the table.
Which may have led to some of this confusion.
Agreed. That's a draft that really is supposed to have gone to protocol and not to come here. I think that's what's confusing everybody.
Correct.
That's the unified
Right,
draft.
what's on the table right now before the members are changes to the specifically named protocols with that statement that Brad read about the 10 micrograms of epi, 2 to 5 minutes, that's all that's being voted on in those specific protocols. The unified thing that's been floating around, that's a discussion item in protocol right now. Other comments or? Okay, let's move to vote then on the, again, we'll read the motion. The motion is to add.
Well, to add the IVP language that Dr. Kaufman has written to all protocols where pressors are being given as part of standing orders.
And medical talk where they exist currently.
Yeah.
Where they exist currently, we're not adding any other new protocol.
Excuse me, to clarify, this still has to go to CMAC before.
Of course, yes.
Correct?
Oh, yeah.
Yes, it would be in the regular cycle after CMAC.
Thank you.
Okay, this will be a roll call vote as well.
Give the language.
It's Paul's language.
Could you read the statement again?
I just want to make sure I have it correct.
Administer epinephrine 10 micrograms IV push slowly over 1 minute. May repeat epinephrine 10 micrograms IV push every 5 minutes, maximum 50 micrograms. Titrated to a systolic pressure greater than 90 millimeters of mercury.
Okay.
Thank you for your
That
language.
is the language that will appear in the mentioned protocols only, where they currently exist, either standing order or medical control option. Roll call vote.
But I just one issue.
Yes.
I didn't hear the protocol for cardiogenic shock, though. That uses pressors.
It is in that
So
protocol.
it's in that grouping as well?
Correct. Where it exists, whether it's standing order or medical control option, where it exists in that protocol, this will also
I
exist.
just didn't hear it in the...
No, wherever a pressor exists,
Right, I heard
this
that.
would be another option.
That's why I'm clarifying.
Clarify from, it's 501A, 500A, 500B,
504.
504B, 510, 515B.
That's it.
Well, reading the titles would have been helpful.
True. To answer your question, yes. It's there.
Okay, that's...
Okay. Any other, roll call vote, please, unless there's other, hopefully there isn't. Let's vote.
Can I call one clarification? It's not in 505D, which is chemical pacing.
Can I call the question, please?
He's called the question,
Yes.
that's done.
No, don't do that, because we have to vote on calling the question. We're going to move to vote.
Okay. Okay. Robert Winchell,
In favor.
Joseph Schenker.
In favor.
Nicholas Alexandru.
Yes.
Christopher Graciano.
Against.
Against? Kevin Munjal.
In favor.
Cindy Basilios.
In favor.
Dario Gonzalez.
No.
Glenn Esteda. Bradley Kaufman.
No.
Doug Isaacs.
Yes.
Nathan Reisman.
Against.
Jeffrey Ravitch.
In favor.
Louis Marshall.
Yes.
Pamela Lai.
No.
Laura Ivacoli.
In favor.
Peter Wire.
Abstain.
Paul Barbara.
No.
David Benelli.
Affirmative.
Confusing me. Celia Quinn.
In favor.
Mark Cantor.
In favor.
Charles Martinez.
In favor.
William Fisher. Robert Krupe.
In favor.
Jessica Van Voorhees.
In favor.
Arthur Cooper.
Dr. Cooper.
In favor.
7, 8, 9, 10, 11, 12, 13, 14, 15, 16. In favor. 1, 2, 3, 4, 5, 6. 6 opposed and 1 abstained.
So motion carries 16 for, 6 against, and 1 abstain.
So I believe that concludes the action items from the Medical Standards Committee. The Medical Standards Committee will meet again on September 4th, new date, right after Labor Day. That's it. Thank you very much.
Thank you. Now we'll go back to the regular order of the meeting. So approval of the minutes from the previous meeting. Can I have, unless there's corrections, a motion to approve? Second? All in favor? Correspondence report.
Okay. Sorry. Okay, from the fire department, we received PCR monthly inventory control report for May 2018. In addition, non-compliant PCRs, we didn't receive PCRs from the following agencies: Bayside Community VAC, Bedford-Stuyvesant, Bravo, Broad Channel, College Point, East Midwood, Flushing Community VAC, Fordham University EMS, Glendale VAC, Middle Village, Roxbury, and Brogsden. All these agencies, as far as we know, still exist, so if you're a medical director for any of these agencies, reach out to them and find out why they're not submitting PCRs. We had a public notice from New York State Department of Health, certification revoked, Alexandra Serrano, EMT number 264928. Certification revoked as of May 21st, 2018, and she's a resident of the Bronx, so she probably works for somebody here.
Or did.
Or did, yeah. Letter from New York Presbyterian announcing the appointment of Dr. Raul Sharma as the new Chief Medical Director of New York Pres EMS. We received a letter from Mount Sinai regarding whether we need online medical control for STEMI. That's going to the protocol committee. And the following were sent. We sent out agendas, minutes, and associated attachments for this meeting. We sent a letter to Bensonhurst VAC granting extension for their glucometry training for BLS. A joint letter from New York City REMAC and Fire to regional hospital leadership was sent out explaining the stroke initiative and its regional implications. An email was sent letting us know that EMS Services, Inc., their suspension in Nassau County has been rescinded by that county's REMAC. ALS Services, Inc. Is that what I said?
Yep.
Oh. CDC, we sent out to all our ambulance agencies a CDC health advisory warning about an outbreak of hepatitis A among drug users and the homeless. That's your correspondence.
Subcommittee reports. Executive committee, I don't believe we have a report because we were just a membership tag, right?
That's right.
Yeah, so no executive committee report, medical standards we did. QA report, Dr. Redliner is not here. Is there, does anyone?
QA really did not meet. We had a meeting that was focused on a patient care restriction. We did what we had to do on that. That is it.
Chime in a little bit. We're continuing to work on the whole stroke initiative, including telephone calls with the state to determine metrics and how data collection will be achieved. So it's work in progress.
Very good, thank you. Training and ed.
training unit did not meet. The training unit did do some work on the sidelines. The CLI curriculum has been revamped and approved by the DOH. There's a class scheduled for the summer. There's going to be one in the fall, so we'll get more instructors up and running. We have a meeting scheduled with the fire department to collaborate on training on the stroke protocol.
Great, thank you. Regional Council, who's got?
It's Dr. Krupi.
Okay, so the Regional EMS Council last met on April 24th. Just a summary, membership, REMSCO approved the appointment of Louis Deutsch as an organization representative from New York State Ambulance Rescue Association District 18. There were no determinations of public need applications that came before us. Transfer Operating Authority applications, there were 2 applications that were approved. Lifeline Ambulance Service, Inc. to UDA Health Management, LLC. The other being Midwood Ambulance and Oxygen Service, Inc. to Instacare, PP1, LLC. Ambulance agencies were reminded to affix the REMSCO security stickers to the front windshield of all ambulances. Security stickers are utilized to allow movement tunnels and major roadways during large-scale events. There were no new enforcement actions from New York State Department of Health Bureau of EMS Operations Unit. The following requests for extensions for implementation of BLS commentary, KQ honored by REMAC for NYPH, New York Presbyterian Hospital EMS, and Fordham EMS. REMAC reported to KQ that the following decisions were made in response to the current shortage of Tiazin. ALS units without the Tiazin make complete protocols without that medication as long as it remains in shortage. REMAC also reported that the discussion is occurring regarding STEMI PCI centers and changing the regional protocol procedure to no longer require OLMC directions for transport. There's also discussion of advisory approving the regional use of BLS providers, hemostatic dressings, and which was approved. Approved procedural change, allowing the use of supraglottic airways without waveform capnography when there are more patients than waveform capnography units until more resources are available. This was an emergency change. There's also a new REMAC biomedical tag. It was formed to review and evaluate new medications and technologies. There were also nominations for EMS awards. Our EMS awards dinner took place. That was a very nice event. Unfortunately, some people couldn't make it because of the holiday, but we're gonna remedy that at our next meeting. But the following individuals were nominated for awards: registered professional nurse Megan Farley, agency Park Slope, VAC, leadership Nancy Benedetto, educator Gail Larkin, physician Paul Barber, quality safety Malcolm Redland. Just to be aware, there are nominations for at-large seats that be accepted until June 4th, 2018. That's my report.
All right, thank you.
Very good.
CMAC update.
I apologize, I did that right.
I can do some of the things I have my notes. You want to say yours?
Whoever wants to.
You go ahead. You correct me if I make a mistake. Yeah. Okay, so we'll make this quick. REMSCO met. There was election for officers. The new director of the Bureau of EMS, Ryan Greenberg, introduced himself and spoke about some of his activities. CMAC and medical standards, Mercy flight protocols were passed, New York City stroke protocols were passed, the collaborative protocols, AMT, were passed. Okay, collaborative protocol AMT for chest trauma was passed. There was a big discussion, which we should keep in our back of our mind if we ever decide to join collaborative protocols, about whether once the collaborative protocol team has decided to create a protocol, do the local REMACs who at one point joined the club have anything further to say about it? And that seems to be a back and forth discussion over there about one of these protocols. The local REMACs argued they didn't have a chance to review it. The collaborative protocol says, you guys joined us, therefore you're bound by our decision, you have representatives, and it's done. So I think this will come up further. The pediatric protocols were postponed, and the state protocols, the New York State BLS protocols were gone over with a fine-tooth comb, and a whole bunch of issues were raised here and there, and they will be brought at the next meeting in September. I would suggest that you people look at them because they're going to indirectly affect us. And if we have something that we really object to them, we should speak now or forever. Hold on, guys. Okay. The Systems Committee had nothing. There were no appeals. There will be a few appeals at the next meeting. And that basically was the meeting. Did I leave anything else?
Yeah, go ahead.
collaboratives.
No, I was just gonna talk about the collaboratives.
Yeah, I was too. but
Just
go
one
ahead.
minor
Yes.
correction. The pediatric protocols were not, BLS protocols were not put off. It was, most of the BLS, most of the recommendations from the MSC committee were incorporated into the document, but there were certain issues that CMAC asked the MSC committee to take back to and discuss further. We did so. We did so, and those comments have been, again, forwarded to the collaborative.
Right, so the intent of being on the collaborative, the intent was to bring it forth for a reading, the MSC gave their input, and to get feedback before the September meeting.
Correct.
So,
About the state.
well, the BLS protocol, but it's,
The state
they're gonna
protocol
eventually
as
be one
opposed
in
to
the
the
same.
ALS collaborative protocol, which is
Right,
something
but
different.
the collaborative group is working on the state BLS protocol, a lot of the same people.
That's right.
Collaborating,
Right,
but it's not.
so call it a collaboration, but it's not the collaborative protocol.
Right, that's a big difference, because
Yes.
we're not members of the
The other
collaborative.
thing is that EMSC got funding for an additional 4 years, that wasn't mentioned, right?
We did get funding, not quite 4, but yes, that's
Okay.
right.
So I wanted to bring that up, you're not going anywhere.
We're not.
So their input's being incorporated, but as you said, if you have you should look over those protocols, if you have commentary, the committee would love to hear that before September, so that can be incorporated.
Who's the chair of that committee?
Which one?
The BLS.
BLS.
Daily.
Staley?
Yes. Dr. Daly, you can send all your comments to him, he loves getting phone calls and emails.
And we meet again in September.
Anything else you want to say?
Well, I just wanted to mention the collaborative protocols. One of the things is that New York City, Nassau, and Suffolk County are the only 3 regions that are not either on the collaborative protocol or using the collaborative protocol. So the 3 regions met last month, and we talked about adopting the collaborative protocols without actually joining the collaborative. That's an option. So that way, essentially, we'll have one set of protocols across the whole state. There are some issues with if you join the collaborative, you have one representative on the collaborative, and that person brings forward your position on certain things, and if they vote on it, then your region accepts that. Also, if the state approves any of the changes to the collaborative protocol, any region can adopt those changes because they're approved by CMAC. So we're doing a crosswalk with the 3 regions' protocols in terms of medication and.
We've completed the comparison, now we're waiting to get a date together to actually sit down and talk.
So I think that we're not as far off as we think we are, and I think it would be a good idea to finally move towards one set of statewide protocols. So that's just for information.
So is that, so then that information on the crosswalk would be brought to here, to this body?
Yeah, well, this body would have
right,
to
and they could
vote
discuss,
to-
but.
Or we
I
could have
think-
our own downstate collaborative.
Yes, yes, the second,
Which is fine.
the better collaborative, whatever you want to call it.
Better collaborative, yeah.
Right.
But the other, Nassau and Suffolk are in favor
So,
of
big step to
either
start.
having our downstate collaborative
I see.
protocols or having one set of protocols for all 3 regions. Because we're so close together, there's so many transports across, regional lines back and forth, and crews get confused and protocols get confused, so I think it'll be better for patient care.
Thank you. Unfinished business. Do you have any unfinished business? Anyone have any unfinished business?
At some
That's,
point,
I have that on the new business.
Jeff, at some point, we're supposed to do a CP tag report out. Community paramedicine tag
Okay.
report out.
Would you like to do that now? Is unfinished business? So, community paramedicine tag, I guess, has met, and they have some report out for us. Dr. Mantel?
All right, hi everyone. First of all, thank you to the REMAC for putting together a tag on community paramedicine. It's obviously been a long time coming. And thank you to the members of the tag that have participated. And again, we are welcoming of additional contributions and participation from everyone here and even beyond the REMAC if they'd like to contribute. So we've met a couple of times over the year. There was a little bit of a hiatus over the last few months as there was a lot of activity around the state around new legislation. Unfortunately, that activity seems to have come to a little bit of another pause. So we are resuming under our initial purpose, which was to kind of explore what was possible under sort of current existing Article 30 and regional and state protocols and guidelines. So our group is sort of formalized around a sort of objective and purpose statement, which I'll read for the group. Our purpose is to develop guidance to the REMAC on its role in providing regulatory oversight of EMS systems and EMS providers participating in community paramedicine, mobile integrated healthcare, and telehealth programs. The tag seeks to clarify what is currently permissible under Article 30, CMAC and New York City REMAC regulations, and to make recommendations to the REMAC regarding potential general operating procedures, protocols, training, and QA standards for such programs. Again, we welcome feedback on that as well as guidance on some of the issues. The type of program that we are focusing on is the type of program that is currently in place in at least 2 hospital systems in the region, and that is around unscheduled care in response to a potential emergency situation. The approach that we're taking is to focus on identifying what REMAC and REMSCO has authority over and what it does not. The report hopes to be able to define some of the key components of a community paramedicine program, including what are the appropriate triggers for a community paramedicine call, to be able to try to describe training standards and knowledge expectations, the characteristics of an agency that seeks to perform community paramedicine, characteristics of partner agencies requesting or receiving community paramedicine, set QA expectations, and describe the role and responsibility of the medical director. We expect that the report will recommend certain requirements around what type of encounter is appropriate to be triggered and what's the mechanism of triggering a community paramedicine response. We decided against making a lot of the focus around advocacy around community paramedicine external to what the REMAC or REMSCO have the power to do.